It's now my pleasure to introduce our first keynote, Dr. Hsien Seow. Hsien is a Canada Research Chair in Palliative Care and Health System Innovation and a professor in the Department of Oncology at McMaster University. He publishes health care and policy research focused on improving care for patients with serious illnesses, including promotion of the uptake of a palliative care approach in primary care and on improved communication with seriously ill patients and families. He also is the co-author, I forgot to bring your book up, Hsien, but of Hope for the Best, Plan for the Rest, a book to help patients and families facing serious illness navigate and be knowledgeable and prepared for the kinds of challenges that they will face. This book will be on sale today until after lunch. So if you want to purchase a copy of the book, that will be available during the lunch hour. He's also the co-host of the Waiting Room Revolution podcast with Dr. Samantha Winemaker. The Waiting Room Revolution, did I get it wrong? Oh, okay. The Waiting Room Revolution website has lots of resources that can help unlock a better illness experience. It is now in its 6th season and is ranked in the top 1.5% of podcasts globally. So if you're wanting to know whether or not we've arrived on the global scene, Hsien, thank you for that honor. So, welcome you to up. Hsien is also a great collaborator and an all-around amazing colleague and friend. Thanks for coming. Welcome.
All right, good morning. Thank you, Doris, for that. Warm welcome, and thank you to everyone. I love being here at the West Coast. For those who don't know me, I'm Hsien Seow, and I want to share a little bit about myself. I want you to introduce you to my mother. This is my mother. Her name is Swatine, which means snow pearl in Chinese. She is an amazing person. She is, my hero in life, really, my inspiration. She was the first person in her family to go to college, university. She got a master's in economics. She was a senior vice president at Singapore Broadcasting Corporation, and she gave all that up to come to Canada with my dad, my brother, and myself for a better life, in a way, so that we could grow up in a different place, in this beautiful place that we now call Canada. We had to get used to the winters, because in Singapore it's on the equator, it's very hot. We got sweaters every single year for Christmas. We got adjusted, and we had, she sang in the church choir, and I learned from her how to love, how to be generous, and to see the good in people, really, to appreciate what people have to offer, and to do your best. So I thank for that. One day, as life was going on, she felt a lump in her breast. She went to the doctor. They said, don't worry about it. It's nothing. You're overreacting. So she left it. And when it grew bigger, she went back and they discovered it was breast cancer. And in that instant, really, it changed our lives forever. We started on this roller coaster journey, I would say, of many decisions about, lumpectomy or mastectomy and chemotherapy and these cycles and radiation. And I would say throughout that whole journey, we were in the dark. We felt unprepared of what it was going to look like, overwhelmed for sure, not really knowing what to expect. They talked a lot about white blood cell counts, but never once really asking what counted to her and what mattered and how to make sense of this. There was a time when we actually reached a remission, but I'm not sure we knew exactly what that meant. And what to do with that. And other than just to keep hoping and praying and being positive, we then went to another stage where it came back and it spread to her lungs. Again, I don't think we knew exactly what that meant, the meaning of that, other than it led more chemotherapy, more nausea, more hair loss. And I know that we never heard the word palliative care. I know that we were scared and frustrated. My dad, having to think of what all this meant. And I don't think we realized that when she was losing weight and on oxygen, that time was running out. We didn't have that concept to use that time in a different way. And when she was admitted to the hospital, we didn't know that would be the last time, and she would never leave that hospital. See, the thing is, that story that I just told, it happened 33 years ago. And I can tell you that in the qualitative interviews that I do with patients and families and providers in the hospital in a bed, like that, not too different from that. Well, maybe it's a nicer bed then, a nicer, maybe a little bit newer equipment. It's the same story. It's the same experience and journey. Yes, the medical care and treatment, and all the way through, I would say that the providers were caring, but we could not understand what was happening. So I have worked to try to figure out how we can change this story, not for me, but for the patients that are on this conveyor belt. They are the chocolates in this conveyor belt of healthcare. And yes, Ethel and Lucy, when I'm with Sam, Sammy, she likes to be Lucy. I don't know. I'm like, that's fine. I'll be Ethel. But the healthcare providers feel the same way. They're sort of rushing around. But it is really those patients that are stepping onto that conveyor belt every single day with a new diagnosis and trying to make sense of what this means. And I will tell you that if you imagine being these chocolates, don't have a voice, have lost what is happening. They don't know what's coming next, behind, the next thing. And that is the problem. I won't talk too much about the problems because we would be here a long time. But in a nutshell, our system is broken. It has become this conveyor belt, this robotic, we're widgets in a system, including everyone in this room. And how do we reclaim that power? That's what I want to talk about, because there is hope and there is a way. When we talked about how can we do something different to make a difference, I'm hoping that I can share with you what I've learned. The answer to a different future is to invert the pyramid. Okay, let me explain the pyramid. We, in this room, are the 1%. We are the palliative care specialists, the experts. In a way, we've drank the Kool-Aid. We know what palliative care is and aren't afraid to say the word and the difference between a palliative approach and a palliative care. Okay. We are in this room, in this 1%, trying to help all those patients, those chocolates coming down, and do the best we can in the last weeks and months, really. And maybe we're doing a really good job in getting at 8 months before. But there was a whole journey. That story with my mom was 4 years. I was 6, and she passed away when I was 10. And we didn't know that this would be her last 4 years. The BC Center and many of us in the field have been working on programs to train and operationalize a palliative approach to our colleagues, generalists, I would call them, our family physician colleagues, through lots of amazing programs, the Serious Illness Conversation Program, quality improvement projects. Very important. It's, maybe there's a feeling the needle isn't moving fast enough. And I would say we've also, across the country, but especially here in BC, as a leader in engaging the community and the public, right, through death cafes and various approaches. But I want to say that there's a group in the middle, the patients and families, who are an opportunity for us. They are not only the people that we are trying to serve, but they are a coalition of powerful voices that we can engage and collaborate with to make system change. And in fact, if we invert this pyramid and turn it upside down, you can see the number of people who are in the community and the public and in patients and families who will have the power to change that healthcare conveyor belt. That's my belief, because I do not believe that we will be able to move this triangle from the top down or only from the bottom up. It's going to come from the middle out, and patients and families are in the middle. So let me share with you what I've learned with engaging directly with patients and families. So, our story really started with Dr. Winemaker, Sammy. She's a palliative care physician. She works in people's homes. We've been trying to do system change for years through research and evidence that an early palliative care approach has all these benefits, which we've seen through many, many studies. We thought, actually, if we can just take our end-of-life food truck, our palliative care food truck, and go upstream which is what the evidence says, and we just really explain to people the benefits, they would get it. They would want it. I mean, the evidence is so clear. When a palliative approach, the elements of that could have been introduced when my mom first got cancer, or when, or any other disease, to make sense of what is happening. And lo and behold, I would say we were maybe a bit surprised. This was actually a lesson that took a little bit to learn, that, like in this picture, we did not have a line in our food truck. People were not interested. What they were hearing and seeing when we said, yes, an early palliative approach, they saw this on the menu, they didn't want any of it. What they heard was, you're giving up on me earlier, you're giving me, it felt like a death service in a way, even though that's not what we do, but that's not what they were hearing. And in fact, I made this slide when I really thought, we were working really hard anyway, we were interviewed by Brian Goldman, actually, Sammy and I. Episode hasn't come out yet, I don't know. But anyway, he asked us at the very end, he said, so Hsien, people will be listening, and how will you describe palliative care? And I was like, you would think I would know how to answer that. But in fact, palliative care is used in so many ways in the system. You're a palliative patient, a palliative stage, it's a service, it's a specialty. They're palliative now, it's a diagnosis. There's only one other word I could think of that is used in all these ways, and it's a swear word that starts with F. Because there's no other word that can be used in sort of any way. We kind of use it in so many ways. So I could not explain, me, who has been studying this for 20 years, of like, what is palliative care at the end of the day? So I think we realized we needed to take a step back. We needed to deconstruct what it is that we all do, or what we know we've seen the value and beauty and power of, and really think or articulate what it is that we do so that others could do it too. We deconstructed the elements, and we thought about all the thousands of patients that, other palliative care doctors, but Sammy has seen at the bedside, who are in the dark, and those who had a different journey, which we call in the know. And those who were in the know felt more in control, had more choice, they were prepared. While we didn't change the illness, we changed the experience. And both the patient and the family knew what was happening and could make sense of that, and therefore they could make choices that reflected what they wanted. So how do we get from in the dark to in the know? We broke down the magic of a palliative approach into 7 keys, into 7 actions. If you have been following our podcast or our book, you'll have heard us talk about these. But I'll just very quickly walk through. But these are these metaphors. I'll tell you, it took us a long time to come up with these in a way. We co-designed these with patients and families because it is in the language, in the framing, that was going to make that line for that food truck longer. And so the first key was this idea of walking 2 roads. That palliative care is really about, the approach is really about walking 2 roads, hoping for the best, but planning for the rest, and being aware that there is some what-ifs that you may want to think about so that you can be more prepared. It was the skill of zooming out. Sammy would say this is what she does 90% of the clinic visit, is to help people get out from the weeds of the illness, the treatments and the tests, and see the big picture of the illness and know that there are stages. There's a beginning, middle, late, and end stage, and to understand what to expect in each stage so that they could maximize quality of life, but also feel true to what was happening, know what to look for. It became like a roadmap for people. Their style, knowing your style, how you have faced challenges in the past, and leaning into that, so it's going to sort of, in a way, be heightened when you face an illness. And so those personality traits are going to follow you, probably. I think you die as you live, but you live as you live. And your family around you, your inner crew, we call them, to appreciate that and know how they're going to fit into that story. And so that you're not sort of overwhelmed or caught off guard when you notice the same patterns happening again. It's sort of getting ahead of that. Customize your order is really about bringing your values forward. And this one smells a lot like, it has a lot of overlap with advanced care planning. But it's actually, I think, broader. It's sort of, a little bit bigger, because it is about, while you are still able to make decisions, that at every decision point, you can bring your values forward and make the care and that experience yours and uniquely you. The ripple effects is the acknowledgement of the inner crew, the caregiver role, how most of the care, 90% of the care is delivered in the community, and who is going to be involved, what is their role, are they prepared, are they supported? Connecting the dots is this idea of the navigation role, and that someone in your team has to be the manager. Those who had a better experience had somebody who is the glue of the team. I know it's not fair, but those, any one part of the system is not well connected, and those who had some way to bring them together did better. And last but not least, the invite yourself. The idea of not waiting for no news is good news, but the idea that you had to invite yourself and find your voice because it was their life. And so these actions, these 7 keys were really key. Actually, someone who listened to our podcast made like Tai Chi movements to them. So anyway, in our next season of our podcast, it's on YouTube now. You'll see them. I didn't do them with you here, but maybe after I'll show you. Anyway, so what's so innovative about this? In this room, those metaphors I used, let me just go back. You do this. You don't need these metaphors. You do this when you have clinical practice. You do it intuitively. What is innovative about this is what we are saying is we changed the language so that it was accessible to patients and families so they could do it. We are activating patients and families so that they can be the ones to initiate and ask for this. They were actionable so that they could move from the backseat of their illness to the front seat and take more charge or be more in control if they wanted, or somebody on their team. And most importantly, these actions can be done at any point in the illness. And after, I think we've started this, 4 years now, I think 2020, during COVID, we were there. It has been an amazing surprise and journey to realize, to discover that patients and families listen to the podcast and start using the language right away because they've been seeking this way to get their voice out. Okay, so we set out our goal to improve that patient and family experience, to change that, that feeling of just being that, customized chocolate, and to find individuality in that. And so we created the waiting room revolution. We do believe that we need a revolution in healthcare. It is going to require patients, families, and providers in this revolution. And so we gave it that name. And we didn't call it the Palliative Care Revolution for all the reasons of the food truck, but the waiting room was that place where people felt hopeless and powerless and sort of scared, just with no power. And we wanted to flip that on its head, invert the pyramid in a way. So it became, the revolution is that when patients and families go in there, they're in charge. They know what questions to ask. They know how they're going to tell their clinicians and have that team work with them, not the other way around. That's the revolution we're looking for. So we sat on these keys, or we sort of, had done lots of work trying to get them, and how did we spread this message? That's the story I want to share now, because we've learned a lot in that process too. As Doris alluded to, we started with a podcast, which was, in it, we were never on social media. We are the least likely people to do anything techie, I would say, Sammy and I. Especially Sammy, if I can say that. She's always like, "What's Zoom? What is Zoom?" I'm like, oh, "Click on this link." I don't know. Anyway, but we recorded these keys in a podcast format. We talked to patients and families who were telling us their stories, where we were they weren't using these metaphors, but at the heart of it, that's what they were doing. And we put it out. We thought, I got my dad to listen again. He's like, "What's a podcast?" I'm like, "Just press play so I get a like, Dad, please." Anyway, but lo and behold, we had listeners. People followed it, and it took off. We are actually now in season 9. Season 9 is starting in a couple weeks. We passed 100 episodes, and we have interviewed people from all over the world not in the desire to provide palliative care, but in the desire to improve the patient and family experience. The guests that we are trying to reach are maybe in a way outside of this room, and that's outside of the 1%, because we're trying to build the coalition of people who have the same mission as us. We've talked to, Nahid, of course, Nurse Biff Naked was on our show, who actually is a doula and is a breast cancer survivor. But we're listened to in 100 countries. I do not know people in 100 countries. So somehow this thing is has some momentum, over 125,000 downloads, and again, we try to have themes in the season and keep growing. We like it because we learn something from every guest, of course, but we're building that community. We're strengthening that pyramid so that it is not only us in this room who are responsible for fixing that conveyor belt. It's not going to happen if it's just us. Okay. We're very, honored. Our book, Hope for the Best, Plan for the Rest, is just reached its 1-year anniversary. It's been out for a year. It has been so exciting to see people read it, and patients come up to say, I kind of was frozen and I didn't know what to do, and this book gave us the language of what to do. And in fact, even people highlight it and stuff, but even for families who are said, my mom is the kind of person who doesn't want to talk about this, but when she read it, she found things that she's like, I don't want to talk about that, I don't want to think too far, but I do want to ask these questions because I should know the answers to these. So that has been one of the funnest parts. People say it allows them to take things into their own hands, essential listening, etc. But in a way, to this audience especially, Sammy and I didn't really do anything that you don't already know how to do. But it was in the language, it was in the packaging in a way that the patients and families could access it. And I want to just draw your attention to here, which is what we thought was the most interesting. The bottom right, Carly Bree, it said, it's a must listen for medical students, family doctors, and anyone involved in care. It changed their approach to patients, how they approach patients. We thought, in a way, we kind of did all this because we were so frustrated with only teaching these really great programs to healthcare providers, but not seeing that translate to the bedside and to the system, frankly. So we sort of said, let's turn our attention to patients and families. Let's go direct to them with the same amazing education that we've been doing, and what will that do? And I can tell you, that middle is getting activated. But we thought we would get run out of town by the providers. We thought they'd be angry because, they're trying, they are the Ethel and Lucy's here. They're trying as hard as they possibly can to do the best care they can. And what we realized in the last year or so is that they are stuck in the same system. It's like they're cogs in the wheel too. They feel demoralized, hopeless, helpless, the same feelings in many ways that patients and families feel. And they don't know how to get out of that either. They're not trying to provide bad care. They're trying to do the best they can, and they don't know how. So we realized, I think, in a way that the benefits for patients and families who are reading the book is they were saying care is transactional, like on that conveyor belt. But what brought them to medicine was the relational care, that connection. And that's what palliative care does every single day. So Sammy will say, as many palliative care providers, they don't burn out because of the clinical care. They burn out because of system issues. So the clinical care, that being with, is what sustains her. It nurtures her, in fact. And she would say that what she teaches her residents, she has residents in her car all the time, she would say is the best medicine is to just listen, to be with. First, we don't necessarily have to go with an agenda. We go first to listen and understand what is it that they need. And so that, I would say, is what you all do and are trying to teach others to do. But in every clinical unit, in the hospital, oncology units, nephrology units, they are not realizing that they're stuck in the transactional. Or maybe they do, I know family physicians in BC do. They're trying to get back to the relational and don't know how. They're feeling what's on the left, reactive, frustrated, burnt out. And we offer, in palliative care, hope, satisfaction, fulfillment in a way. And so I think, let me just pause here, because I don't know how deep this is, but what I think I'm saying is we, as palliative care providers, fans, groupies, I'm probably more a groupie, I'm not a provider, but we have the secret, actually, of how to save the health system. See, if we could teach other healthcare providers, and frankly, patients and families, how to get what we offer, they would not feel hopeless, but hopeful. Even if they can't change the illness, they can change the experience. And yes, there are system issues that overlay that. But that connection between clinician and patient, we can change that. That is something within our power. And if we could share that, that pyramid would invert. So it is about not feeling like we have to own it, or I don't know, no one's talking about ownership, but feeling like we are the only ones responsible, but recognizing that we actually have something to offer, and we can maybe the education role that BC Center does so well. Oh, okay. I thought it said engage, educate, but it says collaborate. You get the idea. Anyway, we changed our mission. We changed our mission because we knew it was not just about improving the patient and family experience. We had to go back full circle to the providers. Providers had lost the humanness of what they were doing. And so our goal is to put the human back at the center of care, because that is a mission that encompasses providers, patients, and families. All right. That's the only way we'll invert the pyramid. We can't, anyway, okay. All right, so how do we act together? This is the how. Okay, I'm going to try to offer you some suggestions. You could work as an individual. You could walk away here and go, okay, that sounds nice, Hsien. What can I do tomorrow? As an individual, well, we've had lots of people say, recommend people to the podcast. You can tell your patients or tell others to recommend to the podcast. Season 1 is our most listened to episode, and Walk Two Roads, our very first key, is by far our most listened to episode as well. And it's it's free, it's downloadable, but it's I didn't realize this, but I guess in a way, I mean, patients and they can listen to it in the privacy of their own homes without having to talk about it with their sons and daughters or what have you. They can listen to it and think about it and come to their own acceptance of what they need to do. So anyway, you could recommend the podcast, of course. We have the book, but people have read the book in book clubs. We have a discussion guide. It's on our website. It's free. People have used this as a tool to have conversations of things that they could do. And I could see this being used in cancer support groups or Alzheimer's support groups, for example, as a way to open the discussion because the language is safe. We actually have, a couple chapters at the end of what to expect when when death is nearing. But in fact, 90% of the book is about living well with your illness, which is what we all would say is the point of palliative care, right? So somehow, in these metaphors, we got it. We think we got it right. And of course, you can change how you approach your own practice. These 7 keys are words that we coach patients to say, like, help me, doctor, to zoom out. But as a clinician or nurse or social worker or any clinician, you could invite people to say, would you like to know about the big picture? Would you like to zoom out? Would you like to spend a moment here to understand the big picture of where you're at and what to expect next? So you can, as a clinician, use these 7 keys and invite people to know more. We can work with organizations. We've had great partnerships with Health Canada. They listen to our keys. They have a big public health campaign, and they took 3 of the keys and made posters. I don't know, 35,000 posters were printed, but they're free, downloadable on their website. They have a palliative care campaign, and it talks about 3 questions every patient should ask. We also created the B side, which is things we want clinicians to think about before they talk about these conversations, like, is a treatment decision made? What do they already know? And what matters to the patient? So we're trying to do both sides of the equation here. These are both free on Health Canada's website. We've partnered with disease organizations to talk about that roadmap. That zooming out piece of that big picture is one of the most important pieces. Alzheimer's Society, we worked with them on a roadmap of what to expect in the beginning, middle, late, and end stage. And also in those stages, if I'm noticing these symptoms or these changes, what do I do? What is the meaning making? So we give some one-pager, high level, and these are meant, again, to be discussion starters and meant to, change the conversation, but early, things that were approachable to patients so that they could find the very in-depth resources from all the organizations like Alzheimer's Canada earlier. We did this with Lung Health Foundation, which does COPD and asthma and lung cancer. And also we have one for ALS, and Sam keeps saying, we got to do this for the 20 diseases. And I'm like, okay, it will take us some time, but she's right. We do actually need to do that. It's another way to grow that pyramid by working with disease organizations. And last but not least, you can take these keys and adapt them. We have the 7 keys, and people have organizations in the UK, Tasmania adapt them. This is an example from Australia. The Indigenous program of the Experience for the Palliative Approach, they said, we like these 7 keys, and we want to just change the metaphors and the images. So Walk Two Roads is really about swimming against the current, because sometimes it's fast and sometimes it's slow. Customize Your Order is about, they changed it to, infusing your beliefs, your cultural beliefs into the care plan. So take them, use them however you use them in your language and your approach. And last but not least, we have to work together, right? So while I know that compassionate communities, Compassionate Community Ottawa, BC, Canada has, maps of where everyone is, we are trying to find that middle of the pyramid with people who are educators for patients and families. On our website right now, we have a map project. We're trying to find, like hospice educators, community educators, to build this coalition of how we can engage that middle core better. So if that sounds like you can go waitingroomrevolution.com and add your name, and we're bringing ourselves together and activating ourselves. I'm very excited to share, we have been working on a workbook. It is coming out in April. The workbook is a companion to the book and has activities. And I can tell you that we spent 48 hours together, which is a long time with me or Sammy, depends on who's you're asking. But we were like, when the workbook comes out, we have to have a course with a workshop in a box. We're going to have materials for community facilitators and that goes directly to patients and families. So I'm looking at you, Kathleen. So if you're looking for advanced care planning, this is advanced care planning in different words. And actually, at the very end of the workbook, I didn't show this picture, but it summarizes into a one-page summary called My Big Picture. And it's a one-page where you download it and tear it out or write in it, and it tells them, I want to zoom out. This is how much I want to know. This is what I'm hoping for. These are my priorities. This is my team. This is my inner crew, which has their substitute decision maker. But it's not framed as that. It's framed as, how do I get personalized care and you see me for who I am? In that, when you do the workbook, it culminates into that one page, and we hope that people bring it around like a resume or my big picture of who they are, and that is going to change the conversations. Anyway, so that we'll have a workbook and a team with that. And of course, I think this is very aligned with all the work happening in compassionate communities. I frankly think it could be a pillar. And it is it's just another program in the suite, but I could see how the framing of this is activating a different audience in the community of how they want to engage. So instead of, this is an advanced care work planning workshop, this is a how to be a patient workshop, how to be a caregiver workshop. And by the way, when you take the class, you'll learn how to advocate for yourself and get person-centered care or individualized care. I think people will sign up for that. And people will sign up for an ACP course too, but they'll be like, what is ACP? I don't really get it. Anyway, we've had that for a long time. So the conclusion here is this isn't about me or the book or the keys or the podcast. This is about all of the work that we're doing and thinking about what pieces of it can we think about our language, how do we make it accessible to that bottom part, communities, but really, I think patients and families. There's no one in that pyramid who is more motivated to act than patients and families when they get that diagnosis, because their life changes in an instant, and they want as much information. Well, many of them want information to change their story, and they find things on Google, but they don't know what they don't know, and we do. So we want to direct them. We want our work to be actionable, not only by us, but what parts can we empower, train, teach them to do, so we are working together. And last but not least, what parts of our work can we do that can go upstream? So like ACP workshops can be called, how to be a patient, and people will understand that. And that is a little bit more upstream than where many people are finding this stuff. Everyone is invited to be part of the revolution. Frankly, I know it's like you're invited, but really I've solicited you all to become ambassadors in the revolution. And if I had a camera, I would take pictures, but your faces belong here. We are in this. We're in that 1%, and we have to work at engaging that bottom, not bottom up or top down, but I think middle out is what I'm trying to say. And that I do think there's hope. That's what I learned. I think we can invert the pyramid. And I want to leave you with why I'm still excited about this, 10 years in almost, is the hope part. It gave me hope as a researcher that we can see change. But this is a quote we interviewed Stephen Starkman on our podcast last season, I think. We interviewed him while he was using the book, and then as he was going through his journey, and he eventually passed away. This is what his wife wrote us. Finding the book changed the way we lived this past year and how we prepared for the future. Before, he was scared to ask questions, and he didn't know what to expect of his journey. And as a caregiver, the book helped me realize that I needed to ask important questions while I still had the time, so I could navigate, advocate, and honor the way he wanted to live and die. Now, this is the hope that this information, again, not about the book or the podcast, but the information that we gave to the people, which is just unlocking a palliative approach to the public. And what I want to say to this room is, if you read this quote and change it from the perspective of a provider, finding this information changed the way I can prepare my patients for the last year. Before, they were scared to ask questions, or I was scared to ask questions, and I didn't know what to say about his journey. But as a provider, I can now help them realize what important questions to ask while they still have time. And it can help them navigate, advocate, and honor the way they want to live and die. If this allows them to do that, that is how we can invert the pyramid. So thank you for listening. There's no time for this. That's okay. Because we partner with Health Canada, as you can imagine, they really want to know when I give talks and evaluations. So anyway, this is a QR code, but maybe I'll pass it to the team and they can send that out. But this is the QR code to our website, waitingroomrevolution.com. But thank you for listening. But I think there's tremendous ability and hope that we can make change. We have to do things a bit differently, but I think if we think of all the activities we have in our plan and how that connects to activating the middle or inverting the pyramid, I think we can get there. Thank you.